Good afternoon all, my name is Marina Sew-Atjon and I am the acting head of the Bacteriology and Virology Laboratory at our National Clinic. I'm going to be talking today about our experience and response to the chikungunya epidemic on a lab level mainly. So there's several types of tests that are done in Suriname. There's also several labs that do testing apart from ours. The academic hospital has developed an in-house PCR test based on cyber green. The Medical Research Institute carries out commercial PCR testing, and a different lab at the academic hospital also carries out IgM immunofluorescence assays by Euroradium. There are several private laboratories that carry out the rapid tests, which we'll get back to in a second. Okay, so the types of testing Central Lab does is the Euroimmune IgM and IgG immunofluorescence assay. We've received our training from the Erasmus Medical Center lab. They also do our validation and quality control program that's overseen by them. We found the first positive case on the 6th of June. We tested on the 5th of June. Prior to that, we had been sending materials away to CARPHA, which had all come back negative. So this was, oh, I see there's a word missing, a 45-year-old male with a travel history to St. Maarten, the Dutch side. And he got back somewhere in May, it's unclear as to when. And he said his date of onset was the 28th of April. Now the sample was taken on the 6th of May, after which it took about a month for us to be ready with the testing and up and running. So we tested it on the 5th, that's incorrect, it showed positive on the 6th. He has several symptoms including fever, myalgia, malaise. There was no notable arthralgia. And after the positive testing, 2 other family members also tested positive for IgG. The reason we took IgG samples from them, as well as for IgM testing, was because of the date of onset was about 2 months, and we just wanted to do both to be sure to find any trace of chikungunya if it was there. Now it says local transmission was confirmed mere weeks later, but actually that's not quite correct. We had local transmission about 10 days later. We also got results from the academic hospital about 12 to 14 days after our confirmation of the first case that they had found positive cases. We therefore suspect that chikungunya entered Suriname via various routes and not just this one gentleman who traveled to St. Maarten, because the patients that tested positive soon after were in completely different areas without any travel history. So whilst this is our index case, we're not sure that it is the actual very, very first case. Right, okay, so this is a map of Suriname. We've got 2 primary healthcare providers that are state-related. One of them covers the coastal areas, just a very top band, very narrow top band of the country. And they have been keeping a syndromic surveillance record for us starting in, week 40 of 2014. And they've reported very high numbers of cases. Some of these were laboratory confirmed, not all. Due to the high volume of suspected cases, it was just impossible for us to confirm all of these. There was quite a high peak, and they seem to have caught the epidemic as it was going down again. Near the end of the year, the numbers were quite low, and this might either be due to the rainy season and the dry season, or because what our epidemiologists have noticed in Suriname is that near the end of the year, it seems no one gets sick. It's all partying, so no one is sick. And then we have the medical mission that covers our remote interior areas. There's about over 70 clinics that they have in remote areas, as you can see here. And they've also been keeping a surveillance for us. They started a bit earlier than the regional health service. in week 28, and they've mainly been recording, at first it was imported cases from the capital to the interior, and one of the first places to actually get confirmed chikungunya, we laboratory confirmed the new areas, was all the way in the southern area. Does the mouse? No, it doesn't. Anyway, it's just all the way in the southern area, which is really strange because that's 2 plane rides away from the center. So we hypothesized that was definitely an import case. As you can see, their numbers also peaked at around week 41, 44, 40, in the 40s, as with the regional health service. And then it goes down, down, down. Lower numbers near the end of the year, and in the beginning it's also quite low. It's been quite low up until now. Now, the dissemination of chikungunya has, according to our entomologist and epidemiologist, has followed a similar pattern as the dengue epidemics. We've got several problem areas in our capital city, several problem districts where the dengue epidemic is also shows high numbers, and we've seen that chikungunya is also prevalent in those areas. Our entomology department tracks mosquito populations. They place the ovi traps in the hospitals, care homes, schools, and problem neighborhood areas. They then work closely with environmental health of the Bureau of Public Health to reduce these populations of mosquitoes by cleaning up areas. We've had a few countrywide large cleanup areas with the Ministry of Public Works as well, to try and reduce the areas in which these mosquitoes can breed and propagate. We've had several challenges at the central lab. We are a government-funded laboratory, so acquiring the test kits and training, funds for training, has been a difficult trajectory for us. We've also been kind of overloaded with test requests ever since we started in June with testing, so it's been crazy. Another problem that we kind of have is that chikungunya is not a notifiable disease in Suriname. So basically any hospital can start the testing. They have no obligation to validate with us or anything. And one of the problems we've been having is with the PCR that's done at the academic hospital. Due to the fact that they've reported PCR positive cases on patients who've had a date of onset 2 months prior to the PCR sample being taken and run. And all the literature just says that's impossible, so we're a little bit unsure of what to do with this data. The immunofluorescence assay that we do is also labor intensive. It's also subjective to the person who is reading the EFA result. Furthermore, the quality of whole blood samples that's sent to us by, namely the medical mission, is questionable at times due to long travel times and the infrastructure that's simply not fully in place. We have also provided validation of rapid tests for other commercial labs. They asked us to do 2 tests, the CTK on-site Geo, Dengue, IgG, and IgM. Chikungunya IgM rapid test, oh that's a long name, and the on-site IgM combo rapid test cassette. Dr. Johnson has just showed us the sensitivity of these to be very low. We found the exact same things. This, however, hasn't stopped the private labs from using the tests, asking money for the tests. So that's another issue that we are facing. Okay, so 3 weeks after we introduced the chikungunya testing at the lab, we also changed the algorithm to include only severely ill and hospitalized patients, patients with other chronic underlying health issues, pregnant women, and young children. This is because we were simply being overloaded with test requests, and it was a lot of people who weren't very sick, but who were just curious to know, oh, do I have it? Don't I have it? Oh, that's why we changed the testing algorithm. Okay, so the current situation at the central lab is that we've analyzed over 300 samples as of last week. We have found 228 positives, 73 negatives. 22 samples weren't tested, either for reasons of hemolyzed samples, insufficient sample materials. There was a couple of reasons. And 7 that were still in the lab are still to be tested. Right now we receive approximately 10 requests per week from hospitalized patients mainly. And it's important to note that we only analyze data from tests that are received at the central lab. National and international data is analyzed by the epidemiology department of the Bureau of Public Health. And finally, for the future, we're looking towards chikungunya PCR at the central lab as well. We have already received the training for this, and we're just waiting on the funding to get this going. We also want to do some follow-up research in patients 3, 6, and 9 months post-positive diagnosis with IgM and immunofluorescence assay, just to kind of see what the complaints that they're still having are. And so that was it. Thank you for listening.